Presenting fully edentulous maxilla, incorporating guided implant surgery with immediate provisional restoration utilizing Nobel clinician software and the Teeth in an Hour protocol. ImageDent would like to acknowledge and say thank you to the following doctors: Dr. James Franco and Dr. Whit Rominger with Alamo Oral and Maxillofacial Surgical Associates of San Antonio, Texas, and Dr. Robert Laughlin of Alamo Prosthodontics, also in San Antonio, Texas. The following steps and protocols to complete a fully edentulous maxilla-guided implant surgical case with immediate provisionals are: first, create a well-fitting radiographic prosthesis. Next, acquire a 3D CBCT scan of both the patient and radiographic prosthesis, and then convert the 3D DICOM data into the Nobel clinician software. The next step will be to finalize the treatment plan during an online treatment planning meeting with the laboratory, surgeon, and restorative dentists. Once the treatment plan is complete, a computer-generated surgical guide will be ordered and delivered directly to the laboratory for the final step before surgery, which is to create the provisional restoration. These technically complex and software-heavy steps are orchestrated behind the scenes between ImageDent and Authentic Dental Lab and require very little time or effort from the dentists. Before a CBCT can be acquired, the first and arguably most critical step of a guided implant surgery utilizing the Nobel clinician software is the fabrication of a radiographic prosthesis or scanning appliance. In this case, the restorative dentist duplicated a well-fitting denture that was recently made. Following Nobel clinician exact technical specifications, the dental laboratory created this radiographic prosthesis. Notice the buccal flanges that extend high into the vestibule. It is critical that the acrylic exceeds 3 millimeters of thickness in all areas, including the palate. This radiographic prosthesis has 11 gutta-percha registration markers strategically placed. Throughout this presentation, you will see the importance of a well-crafted and precise-fitting radiographic prosthesis. This radiographic prosthesis was then sent back to the restorative dentist for a final try-in. Confirming the intimate and stable fit of the appliance, a bite registration utilizing glue mousse was also taken. This patient is now ready for a CBCT scan. At ImageDent, a dual scan CBCT is required to achieve the technical specifications of the Nobel clinician software. The first CBCT was taken while the patient was wearing the radiographic prosthesis and the bite registration at 0.4 voxels in the maxilla only. The second scan was of the radiographic prosthesis only, placed in the same orientation as the first scan. After both CBCT scans were acquired, ImageDent then placed the DICOM datasets into the Nobel clinician software and successfully registered the gutta-percha markers, allowing the superimposition of the two DICOM datasets. Once the registration process was complete, ImageDent prepares the case for the next step by placing the implants in the approximate areas that were requested by the surgeon. During a hosted online web meeting, the surgeon, restorative dentist, and laboratory technician simultaneously provided feedback to the virtual treatment plan coordinator to perfect and finalize their treatment plan. Each implant is placed in the most ideal position, taking into account available bone width, bone height, cross-arch angulation, and obviously critical anatomy such as the sinus in this case. Each stakeholder has the opportunity to speak up for the respective needs, thus creating a true multidisciplinary case. This case features 6 Nobel replaced tapered groovy implants. Narrow platform implants were placed in positions number 7 and 10. Regular platform implants in positions number 5 and number 12, and wide platform implants in both first molar positions. In an effort to gain optimal AP spread, it was decided to use 10 mm long wide neck implants and plan for a bilateral sinus lift. Upon completion of the ideal virtual treatment plan, ImageDent ordered a computer-generated surgical guide from Nobel clinician and provided detailed plans to the laboratory surgeon and restorative dentist, which allowed them to pre-order only the necessary components to ensure accurate and minimal inventory.
The Nobel Clinician computer-generated surgical guide is manufactured in New Jersey, utilizing stereolithic rapid prototype technology and delivered to ImageDent in 3 business days. This guide is mucosa-borne surgical guide with 6 master insert sleeves and 3 anchor pins, which are critical to secure and stabilize the guide during surgery. To further emphasize the importance of a well-fitting radiographic prosthesis, the surgical guide is literally an exact duplicate of the radiographic prosthesis. If the radiographic prosthesis rocks in the mouth and isn't a perfect fit, then the surgical guide will not provide the level of accuracy and confidence that is required to perform a flapless procedure. The surgical guide was taken to the laboratory, who utilized special components to attach the implant analogs to the surgical guide. These special Nobel Biocare components allow the laboratory technician to accurately secure the implant analogs to the surgical guide in the exact same position, angulation, and depth as our virtual surgery. The easiest way to explain this process is to compare it to an implant level impression, except the surgical guide acts as the PVS impression. Once the analogs are attached to the surgical guide, a soft tissue melange is placed and stone is poured into the surgical guide and around the implant analogs. Upon setting the stone, all components are unattached, leaving a stone model replica of the maxilla with the analogs in the perfect position. From this point, traditional laboratory procedures are followed to fabricate the provisional restoration.
The laboratory has created a beautiful 12-unit screw-retained bridge using the Radica material. Time for surgery. Before surgery can begin, it is critical to verify that the surgical guide is accurately placed before it is secured with the anchor pins. This is achieved by using the bite registration that was created by the restorative dentist at the radiographic prosthesis try-in appointment, and by ensuring that the surgical guide lightly blanches the soft tissue before it is fixated with the anchor pins.
Once the surgical guide is fixated using the anchor pins, it is time to drill. As you can see, insert handles fit precisely into the master sleeves. There is an insert handle for each twist drill. The special twist drills have built-in depth stops that will physically bottom out to the top of the insert handle. The Nobel Guide surgical system provides mesial distal, buccal lingual, and depth control. Once the osteotomy sites are prepared, the implants are then placed through the master insert sleeve. The implant driver also has a depth stop, which provides depth control. The ability to place the implant through the master sleeve ensures accuracy. The final few millimeters were inserted very carefully with a manual torque wrench to ensure that the implant driver depth stop rests perfectly onto the master insert sleeve.
When multiple implants are to be placed, it is recommended to work from side to side. For example, place implant number 5 to depth, then place implant number 12, then number 3, followed by number 14, etc. For additional support, leave the implant mount in the surgical guide master sleeve as you place your remaining implants.
Upon removal of the surgical guide, you can see the amazing benefits to the patient of a guided flapless surgery. The surgery was efficient and predictable, taking less than 55 minutes to complete, including bilateral sinus lifts. In addition, due to the flapless approach, it is minimally invasive, which resulted in significantly less trauma and discomfort for the patient.
And obviously, yes, the implants are placed extremely accurately, just like our virtual treatment plan. Now the moment of truth. Time to deliver the 12-unit screw-retained, non-engaging Radica Provisional. The 12-unit screw-retained Provisional was seated successfully with only minimal occlusal adjustments necessary. Total surgical and provisional seating was achieved in 65 minutes.